Hello everyone, welcome back to my channel. Welcome to the first part of drugs for tuberculosis, and we are going to cover not in too much detail, but yes, we'll be covering all the important points in these series, in these parts of drugs for tuberculosis, so that you really get to know the idea of the gravity and the complexity of the situation that the whole world is going through. So first of all, tuberculosis is a chronic granulomatous disease. It is caused by Mycobacterium tuberculosis. In our country, India, it shares 1/4 tuberculosis burden all over the globe, worldwide, and the whole treatment and the therapy and everything, all the preventive measures and all the things, they are covered under the national program in India. It gives free therapy to all the patients and all the sufferers who are suffering from the tuberculosis. Revised National Tuberculosis Control Program that was launched in 1997, and now it is known as National Tuberculosis Elimination Program, and it was renamed in 2020. And the new treatment guidelines, they were given way in 2021. A large population with HIV, they are having a very high incidence of tuberculosis. So there's a great prevalence of Mycobacterium avium complex, and that is abbreviated as MAC. And then there is a TB co-infection in such individuals. And then last but not the least, you should also know, I have given an overview in the last episode also, that multi-drug resistant tuberculosis is the biggest challenge today, and that along with many other factors why the TB does exist today in 2026, and we are facing it as a global challenge. Now let's come to the historical aspect, a little bit about the drugs that I'm gonna tell you. Streptomycin, the first drug that was introduced in 1947. Then came isoniazid. It was followed by ethambutol in 1961 and rifampicin in 1962. Then there was added on with the role of pyrazinamide. Fluoroquinolones, they were added later to this drug therapies. And new drugs have also emerged recently, like bidaculin and dalaminid, and they are very, very useful for multi-drug resistant tuberculosis. The first line drugs, they are actually having a very high efficacy, and they are having a low toxicity, and they are for the routine use of the therapy. While the second line drugs, they have a low anti-tubercular activity, a little higher toxicity as compared to the first line drugs, and they're generally used when the first line drugs, the person becomes resistant to the first line drugs, or they are used as add-on or supplement drugs. Now we're gonna talk about the drugs, the first line drugs, and the first drug in this particular series or in this particular topic is isoniazid. It's actually a wonderful drug, a very nice drug for tuberculosis. It is tuberculocidal drug, cidal. Okay, that means the fast multiplying bacteria, they are killed, while the quiescent bacteria, they are inhibited. It's a very cheap drug. It's not a very expensive drug. It's quite a cheap drug. And the mechanism of action is the inhibition of the synthesis of the mycolic acids. Now you should know why the mycolic acids, they matter so much, because mycolic acids, they are the fatty acid components of the bacterial cell wall, and that is why isoniazid, which is abbreviated as INH, it is very, very selective for Mycobacterium. There is one gene, INHA gene, and Cas-A gene, that is KASA gene. These are the targets of the isoniazid action, and finally what happens, the DNA synthesis is totally disrupted. There is a high level of resistance to isoniazid, and why it occurs? Due to the mutation in the catalase peroxidase gene, that is abbreviated as CAT gene. Another mutation also occurs in INHA gene, and that is also responsible for the resistance to isoniazid. Let's talk about the interactions of this particular drug. Isoniazid inhibits phenytoin, carbamazepine, diazepam, warfarin metabolism. And why it does so? Because it inhibits the enzymes like CYP219 and CYP3A4. Now, PAS, para-aminosalicylic acid, it inhibits the isoniazid metabolism and prolongs the T-half of isoniazid. Let's talk about the adverse drug reactions of isoniazid: peripheral neuritis, neurological manifestations, paresthesia, numbness, and there is a isoniazid induced toxicity also, which is a very common emerging problem. It can be treated with pyridoxine 100 mg per day. Another important and very severe side effect is hepatitis, which can be caused by isoniazid. It's a really challenging problem. That is all I want to convey about isoniazid. There are many points. If we go in a lot of details, we have a lot of dates, scientists and many other researchers, but for the time being I'm going to brief about isoniazid. Let's go to and jump over to the another drug, that is rifampicin. Rifampicin or rifampin, that are one and the same thing. What is the mechanism of action? It inhibits the DNA-dependent RNA polymerase in prokaryotes. It is a very active anti-tubercular agent. It also actively used as an anti-leprotic drug. Resistance is too rapid and kind of a one-step process that emerges against rifampicin, and the mutation occurs in the target site of the chromosomal changes in the DNA-dependent RNA polymerase. That is the mechanism of the development of the mutation. The adverse drug reactions of rifampicin can be skin eruptions, fever, gut, that is gastrointestinal tract disturbances, liver damage, jaundice. Sometimes the jaundice can be fatal, but this liver damage along with jaundice is a very rare condition, not a very common thing. Then rifampicin is an enzyme inducer. If you remember, INH was an enzyme inhibitor. Rifampicin is an enzyme inducer. Degradation of warfarin, glucocorticoids, oral anti-diabetic drugs, dapsone, estrogen, they all increase. And since they all increase, so a very common side effect seen with the use of rifampicin along with the OCPs is the failure of the contraception. Keep in mind, it's a very important thing you should know. That was all about rifampicin in brief overview. Let's jump to our next drug, ethambutol. Ethambutol, well, I should say the first line, it only and only acts upon mycobacterium. It has a bacteriostatic effect. As compared to the other drugs, it is static effect. It does not kill the bacteria. And bacteriostatic effect, it emerges after 24 hours of the drug given. It inhibits the mycobacterial cell wall synthesis. That is the mechanism of action specifically. The adverse drug reactions seen with ethambutol, they are the optic neuritis. And this optic neuritis, it's basically a dose-related problem. And the renal compromised patients, they are more susceptible to this problem of optic neuritis. Visual changes in the patients who are given ethambutol, the visual changes initially they occur as red-green color blindness, and finally that leads to the final step, that is decrease in the visual acuity. The color vision should be very importantly, and don't forget this, it should be monitored during the ethambutol therapy. Very important point. Now that was in brief overview about ethambutol. Today I'm going to take these three first line drugs. I'm going to sum up a little points about these drugs. Isoniazid, it can be given orally, it can penetrate necrotic lesions, cerebrospinal fluid, and slow acetylators. That is one thing that you might have heard and read many places. Fast acetylators and slow acetylators. These are the different kind of genetically determined individuals. So they have a different genetic composition. So I'm talking about here about the slow acetylators. They respond very nicely to this drug, and no cross resistance with other drugs is seen in case of isoniazid. Now to sum up about little important points about rifampicin. It's an orally active drug. It penetrates the cerebrospinal fluid. Again, next drug, ethambutol, it can be given orally. It also penetrates cerebrospinal fluid. Now, before I sum up and wind up today's episode, I want to give a word about rifampicin. Most of you might have heard about it. Let's talk about it before we finally say bye today. Rifampicin is an analog of rifampin. It is active for Mycobacterium tuberculosis and Mycobacterium avium complex. I told you before, it is abbreviated as MAC. The bacterial RNA polymerase inhibitor is this rifampicin. It inhibits the bacterial RNA polymerase. It shows complete cross resistance with rifampicin. It is also an enzyme inducer like rifampicin. It has active metabolites 2,5-desacetyl rifampicin. The elimination half-life is about 13 hours. It is generally given in the combination of isoniazid, pyrazinamide and moxifloxacin. And this therapy in combination, it is as good as the 6 months therapy. It is also good in the HIV patients who are receiving efavirenz-based antiretroviral therapy. It is very good in that patients also. The efficacy of rifampicin is slightly lower as compared to the rifampicin-based regimens. Rifampicin is used in combination with isoniazid and is very useful short-term treatment for latent tuberculosis infection, that is LTBI. Latent tuberculosis infection. It is a very good therapy for this infection. Also in the patients who are having HIV, it is very good for them also. Drug interactions, they can occur. There is no stoppage of that. Definitely they can occur. And because it also lowers the therapeutic levels of many antiretroviral drugs also. That is also seen. Along with the therapy of rifampicin, the subtherapeutic levels of many antiretroviral drugs is seen. This is one of the drug interactions that is noted in especially patients of HIV. Well, that was a whole lot of information from my end today in this episode of Anti-Tubercular Agents. I think I'm going to come up with 2 more episodes, 2 or 3 episodes more of Anti-Tubercular Agents, and I'm going to discuss the regimes also. So stay tuned. If you like this episode, don't forget to hit the like button. Don't forget to subscribe to my channel. Stay tuned for more such informative videos about pharmacology and a lot of diseases, therapies all around the globe, especially this one made in context with the World Tuberculosis Day, that is on 24th March. Till the next time, thank you, take care, bye-bye.